Medicina veterinária é sobre diagnóstico completo e precoce. Com a IDEXX, a sua clínica pode realizar um check-up 360 em poucos minutos. Com a IDEXX, você tem teste rápido SNAP, hemograma no ProCyte One, um perfil bioquímico amplo, incluindo o SDMA no Catalyst One, e agora concluímos a urinálise com o A e com o nosso mais novo DX. E sabe o que é ainda melhor? Todos esses resultados ficaram prontos em menos de 15 minutos. Viu só como é rápido obter o diagnóstico 360 do seu paciente ainda durante a consulta? Agora com os resultados em mãos, pronto para você fechar o diagnóstico do seu paciente sem complicação, eficiente e no momento que você precisa.
Hello and welcome to today's webinar brought to you by IDEXX. Updates on the diagnosis of pancreatitis in dogs and cats, presented by George Steiner and Beth Schooley. Okay, Dr. Schooley, are you ready to get started?
Yes, sir. Looking forward to it. Hi, everyone. Thank you so much for joining us today. My name is Beth Schooley, and I am a internist who works for IDEXX, and I'm really excited today to introduce Dr. Georg Steiner, who's going to be talking to us about some updates on the diagnosis of pancreatitis in dogs and cats. For those of you who don't know Georg, who I'm sure many of you do, Georg received his veterinary degree at Ludwig Maximilian University in Munich, Germany in 1992. He's board certified by both the American and European Colleges of Veterinary Internal Medicine. In 2000, Dr. Steiner received his PhD from Texas A&M University for his work on canine digestive lipases and their use for diagnosis of GI disorders in the dog. In 2012, he was recognized as a fellow of the American Gastroenterology Association. He is currently a reagents professor and university distinguished professor at Texas A&M. And in 2016, Dr. Steiner was named the Dr. Mark Morris Chair in Small Animal Gastroenterology and Nutrition. He serves as director of the GI laboratory at Texas A&M and is involved in a wide variety of research in small animal gastroenterology. He has co-authored or authored more than 430 peer-reviewed articles, 110 book chapters, and 500 research abstracts. And in addition, he serves as the chair of the Executive Committee of Distinguished Professors and as the faculty liaison to the Vice President for Research at Texas A&M. On top of all of that, he also serves as the chair of the board of the American College of Veterinary Internal Medicine. So really excited to have Georg spend a few minutes with us this week and talk to us a little bit about pancreatitis.
Thank you, Beth, and good morning, everybody. So we're going to talk about updates on the diagnosis of pancreatitis in dogs and in cats. And here the proprietary rights notice, you can read that at your leisure. And then here are my conflict of interest disclosure. Beth already mentioned I'm the director of the GI lab, and as such, we do diagnostic testing on a fee-for-service basis. And then I'm a paid consultant for a variety of companies, including IDEXX, but also Nutramax, ISK, Siva Animal Health, Glycos Bio, Bond Pet Care, Hatch, Boehringer, they didn't fit on the slide. And then I'm a paid speaker for a couple companies and get a little bit of grant support, but none of what we were talking about today really should be impacted very much by this. If you read the veterinary literature, you probably know that pancreatic inflammation in both dogs and cats is so much more common today than we previously believed. If you pull an Ettinger from 20 years ago, pancreatitis was described as an uncommon disease in dogs and a rare disease in cats. And if you pull out the last, version, the last edition of IDEXX that just recently came out a few months ago, that completely is different. We now realize it's a very common disease. It's common in dogs, it's common in cats, and by the way, it's common in people as well. In fact, in the Western worlds, this is the most common reason for a gastrointestinal admission to a emergency room. It's one of the most common deaths related to gastrointestinal disease in people. It's a common disease, and it's just as common in dogs and in cats. But what we also need to realize is that chronic disease is really more common than acute disease in both species. It used to be believed, if you can, even 10 years ago, you pull out an IDEXX, it'll tell you that in dogs, pancreatitis is usually acute, and in cats, it's usually chronic. But we now realize that's really not correct, that both of them, somewhere between 1/4 to 1/3 of the cases are acute, and the remainder are chronic. And that mainly has something to do with diagnosis, which of course has improved over the last 20 years, and we're going to talk a lot about that as we move forward. Now, it's important to recognize that not all changes that you find on histopathology, that you find on cytology, if you wish, are necessarily clinically important. There may be cases that are subclinical, and in fact, there are also maybe some changes that are simply not clinically irrelevant. We notice from many different organs that as we age, as the dog ages, as the cat ages, there are changes to the organ. And in some organs, there's inflammatory cells, i.e. inflammation, itis. And in other organs, it's mainly changes of hyperplasia, it's changes of fibrosis, it's simply changes that are associated with age. And in the pancreas, that may be true as well, though so far, it certainly doesn't seem like there should be a lot of inflammatory cells. Now, when you look at the clinical presentation of pancreatitis in dogs and cats, mainly, again, if you read IDEXX, if you read a lot of retrospective articles that discuss many cases, you get a very incorrect idea about the clinical presentation. This is the largest study ever been published in dogs with pancreatitis. These are 70 dogs with acute pancreatitis. And 91% of them had anorexia, 90% showed vomiting, 79% showed weakness, 58% showed abdominal pain, 46% dehydration, 33% diarrhea, and 21% fever. And of course, these are non-specific findings, but what's more important is that if you think about this some more and you look at the paper a little bit more in closer detail, you will realize this is completely irrelevant information. Because these 70 dogs, and even the title says that acute fatal pancreatitis, these dogs all died of their disease process or were so severely sick that the owner and the veterinarian decided that the dog was better being euthanized. And so in all reality, hopefully that's not true for your practice. Hopefully not 100% of your patients with pancreatitis die. And just look at the weakness. 79% of these dogs showed weakness. I don't know whether, even 20% of my dogs with pancreatitis show weakness. So that's not a clinical sign of pancreatitis in general. It's a sign of saying I'm extremely severely ill as a dog, and maybe I'm about to die. And so these clinical signs are maybe even more severe than you would expect in your everyday case of pancreatitis. It's also interesting that in this study, only 58% of the dogs were believed to have abdominal pain. This is the clinical sign that is the most common clinical sign in people with pancreatitis. 95 to 97% of people with pancreatitis, acute or chronic, report of abdominal discomfort and abdominal pain. Yet here, only 58% of the most severe dogs with pancreatitis are reported as having abdominal pain, which leaves us to one of two conclusions. Either abdominal pain is not as common in dogs as it is in humans, or we're just not as good as veterinarians identifying abdominal pain as our physicians are. And I would suggest that it's the second, that we're just not as good as identifying abdominal pain in our patients. Finally, 33% of these dogs had diarrhea, which is not really a clinical sign that most of it would say is associated with pancreatitis. So, but 1/3 of these dogs, in fact, did have diarrhea. In cats, it's very similar. This is a compilation that Robert Washabach did in a chapter for Consultation in Feline Medicine. And you can see that the clinical signs are, again, very, very non-specific: 87% anorexia, 81% lethargy, 54% dehydration, 47% weight loss, which right then and there tells you that you're dealing with cats that have mostly chronic disease. And then 46% have hypothermia. Hypothermia clearly is not a clinical sign of pancreatitis, but it's a clinical sign of cats that are really, really sick. And again, these 159 cats, most of them died of their disease process. So again, we have to recognize that what's in the literature reported as the typical clinical signs of pancreatitis may be the typical clinical sign for some of them, but certainly not for all of them, because not all of our patients die. And so I would suggest to you there really is a four-tier model of clinical signs. We have the sick patients with the classical clinical signs, the dog that comes in with a history of dietary indiscretion, shows vomiting and abdominal pain, even to prayer position. Certainly that does happen. But we also see sick patients that have non-traditional clinical signs. We see cats that come in with just anorexia. We have dogs that come in and are reported to be finicky eaters. All of those could have pancreatitis. Then there are the patients who are apparently subclinical. So I have one dog, for example, that I saw that came in with a history of not playing anymore. Well, the dog was 14 years old, and everybody assumed that because the dog was 14, he very well had every right not to be playing anymore, like when he was a puppy. But as it turns out, the dog had pancreatitis. And as it turns out, once we treated the pancreatitis, the owner thought he had a puppy again. Clearly not a dog where we would say that is clinical signs of pancreatitis, but also clearly not a dog that is subclinical. And so I would call that apparently subclinical. Both the owner and, by the way, the veterinarian, 3 veterinarians had said, well, this is just a change of age, didn't think of any clinical sign related to pancreatitis. And finally, there is truly the animals that have subclinical disease. We see those dogs, we see those cats that come in, and maybe we do blood work and the dog or cat is older, and we include a spec CPL, spec FPL, and it's abnormal. But the dog or cat has no identifiable clinical signs. That certainly does happen. And the question then becomes, are these patients relevant or not? And that is a sort of a culture change in veterinary medicine to say, well, maybe we do need to worry about subclinical disease in these patients, just like we worry about subclinical disease in the kidney, right? 20 years ago, we would have not worried about chronic kidney disease in cats or in dogs if they weren't clinical, but now we know, because the disease progresses, because the disease is associated with complications, we do need to not ignore this. We do need to diagnose it. We do need to manage it. Now, what's interesting, if you think about frequencies, is that the frequency from the sick patient with classical clinical signs to the patients that are subclinical goes up. And initially, you'd say, well, that's weird. Usually you'd expect the dogs that have and the cats that have the typical clinical signs to be the most frequent. But then again, if you look at kidney disease, for example, if you think of cats with chronic kidney disease, most of them are subclinical. If you check a creatinine and a BUN and maybe even further diagnostic testing in cats that are older, you're going to find a lot of cats that are normal but have no clinical signs yet. They have stage 1 chronic kidney disease, and that's certainly the most common if you do any kind of routine blood work on older animals. And so it's no different for other diseases. We could say the same about dogs with chronic hepatitis. Most of them are subclinical, and only few of them have typical classical clinical signs of chronic hepatitis. And at the same time, of course, we all have to admit that our level of suspicion goes the other direction. If you see a healthy-looking dog, a healthy-looking cat, you don't think of pancreatitis, just like you wouldn't think of chronic kidney disease, just like you wouldn't think of chronic hepatitis in a dog. And if you see the dog coming in with a prayer position, your first thought is, boy, that dog could have pancreatitis. So diagnostic imaging is important for the diagnosis of pancreatitis. And of course, radiographs, we really need to talk about this. They're not useful for the diagnosis of pancreatitis, but they're useful for ruling out a differential diagnosis. But ultrasound, abdominal ultrasound, is in fact very useful for the primary diagnosis of pancreatitis with some caveats, and we're going to talk about them. Number one, we know that a variety of changes have been reported, whether that's an enlargement of the gland, fluid around the gland, echogenicity changes such as a hypoechogenic pancreas when they have pancreatic necrosis, or a hyperechogenic pancreas when there's pancreatic fibrosis, or a hyperechogenic peripancreatic region when there's fat necrosis. And some have also reported a dilation of the pancreatic duct, but we now believe that that's probably not a clinical sign of pancreatitis, but that's more a variability between dogs and a variability between cats, that they simply have pancreatic ducts of different sizes. Now, that needs to be confirmed, with further studies for how much the pancreatic duct size can go into the diagnosis. But you can see there's a variety of changes that we could see. The problem is that there's also some challenges. And here you see an example of this. And this is an ultrasound of a dog with pancreatitis. And you can see between these two crosses, where my pointer is, you can see there's an area, large area of hypoechogenicity. That would suggest there's some pancreatic necrosis going on. There's some hyperechogenic areas around the pancreas that would certainly suggest that there's some peripancreatic fat necrosis going on. So that would be an image that probably most people would agree on, shows some suggestion of pancreatitis, but not all of them are this clear. And so there are several challenges. The one is that the sensitivity is largely operator dependent and has been very low. That's actually reported in the literature. And it's lower even with less severe disease, and lower with limited operator skill. And so an exact sensitivity and specificity at this point is really not known, because many of the studies that have been done are fairly old. The ultrasound equipment has improved, training has improved. So it's probably not reliable to look at those and say that is the sensitivity of ultrasound for the diagnosis of pancreatitis. And at the same time, the specificity is limited by other conditions leading to similar changes. So, for example, the ultrasonographer Dr. Silke Hecht at University of Tennessee has shown that hypoplastic nodules in cats look exactly like pancreatitis in cats. And so the differentiation of the two is very difficult, especially if you have high-end equipment. We'll get to that. And so rather than telling you what is the sensitivity, what is the specificity of ultrasound for the diagnosis of pancreatitis in dogs and cats, I will tell you that it's the success of diagnostic ultrasound is dependent on really 5 factors. The first one is the severity of the disease. And you've already seen, that pancreatic necrosis is relatively easy to spot. But when you get to mild pancreatitis, especially chronic mild pancreatitis, that may become very difficult, especially because mild chronic pancreatitis is often highly localized. So it may only be in one small portion of the pancreas. And if you recall, the pancreas is situated along the stomach wall and then along the duodenum, lots of gas around. So oftentimes we can't see the entire pancreas on an imaging study. And so oftentimes we're not even able to see the whole pancreas, leave alone evaluate the pancreas critically. It's dependent on the quality of the equipment, and simplistically, we immediately would say, well, if you have more expensive equipment, like a university that pay $300,000 for their machine, that should give you a lot better image quality than if you buy a $15,000 ultrasound machine. But that may not necessarily all be true, because, of course, the higher image quality is also associated, you can see less severe changes. So maybe the hypoplastic nodules would be missed on a cheap ultrasound, and therefore you wouldn't have the problem of differentiating it from pancreatitis. But another one is the timing of the ultrasound. There's been some nice studies that have shown that the ultrasound image can lag 24 or even 48 hours behind what's actually happening in the pancreas. So if you have a truly acute setting of pancreatitis, and you do an ultrasound right at when the animal is being presented, you may actually miss the changes of pancreatitis, and you may falsely say the dog doesn't or the cat doesn't have pancreatitis when in fact they do. Also, The skill of the operator is very important. And the skill of the operator, basically, if you have, have a lot of training and have an interest in the pancreas, clearly your diagnostic skills would be better than somebody who's doing this as a hobby, so to speak. If you only do 1 a week, you're probably not as good as looking at these images and then when you do 10 a day. And finally, the level of suspicion. It's quite clear that, again, we talked about this before, 20 years ago, when pancreatitis was considered to be uncommon in dogs and rare in cats, probably the likelihood that somebody would find evidence of pancreatitis was low. And so if you were trained during those days, you probably are more likely to say this animal does not have pancreatitis than somebody who was trained currently and realizes that pancreatitis is extremely common in both dogs and cats. There's also some advanced imaging. So we're having contrast enhanced ultrasound that mainly has been studied in Japan. Very nice studies that show that it's highly sensitive, highly specific, and you can both identify induced pancreatitis as well as spontaneous pancreatitis. But you do need specific equipment, and so therefore it's not so easy to do this routinely. Computed tomography has been utilized in humans, of course, for many, many years, highly sensitive, highly specific. And so it's a great diagnostic tool in humans. In dogs, there's really not a single study that has evaluated it sort of systemically. And the only studies that have, there's some case series that have reported on this. And in those case series, at least the sensitivity was very poor. So now these case series are old, they're 20 years old, and the equipment, of course, have moved on since then. So it may be a lot better these days, but there's no studies that really demonstrate that. And the other problem with both computed tomography and MRI, as we're going to talk in a second, is that the cost of one evaluation is very expensive. And as you all know, management of pancreatitis can be, especially in an acute severe setting, is often associated with many days of hospitalization, with many ups and downs. And so sometimes you're going to have to make the decision whether you want to spend, let's say, $1,000 on a computer tomography, or you want to rather spend that $1,000 of supportive care and hope that the patient makes it out the hospital. MRI, there really was only one center that has looked at this in more detail. That was at Colorado State University. And they had some good results, but again, there's not enough data to really say this is the sensitivity, that's the specificity for MRI. And again, the same problem of cost related to then the cost of the whole patient is, of course, something that to critically think about. General clinical pathology, CBC and chemistry profile. Now, I could show you any change you can imagine on a CBC and a chemistry profile, whether that's hemoconcentration or anemia, neutrophilia, neutropenia, hypercalcemia, hypocalcemia, hypoglycemia, you name it. You can all find that in pancreatitis patients. And what that tells you is that none of this is really relevant for a diagnosis of pancreatitis, but instead, it is very relevant to systemically evaluate the patient to see where's the patient at. Is the patient having any complication? That's what's the important part. And so it is absolutely mandatory to have a CBC and a chemistry profile in a patient that is suspected of having pancreatitis to, number one, is systemically evaluate the patient, and also to evaluate the patient for potential other differential diagnoses or concurrent conditions. So it is absolutely imperative we have a CBC and chemistry profile. It's just important to realize we're not doing it for the diagnosis of pancreatitis, but we're doing it to systemically evaluate the patient. Lipase activity can be measured by a variety of different assays, and these are differentiated by the substrate that is being used. And so traditionally, you probably are aware, we used to utilize 1,2-diglyceride assays because this is a really flexible substrate. It can be used both on a wet and a dry chemistry platform. Then we had others like triolein, which is a triglyceride, which is only available for a dry chemistry platform. The Fuji system, this was developed by Fuji in Japan. And then finally, DGGR, which is a synthetic substrate. And it's interesting because until very recently, this was only available for wet chemistry, which really limited it for the most part, to laboratory systems rather than patient side use. There was one analyzer that used it patient side, but all other analyzers used it in a send-in laboratory until recently, because recently, and we're going to talk about this in more detail, the first assay for dry chemistry was developed. Sorry, this should say dry chemistry, the Catalyst Pancreatic Lipase test. We're going to talk about more in detail. What's important to realize is that just because you use the same substrate, so for example, if you have two assays that use 1,2-diglycerides as a substrate, they're not measuring the same thing. They're measuring a different combination of lipase, and just like the DGGR lipase assays don't measure all the same thing. And the reason why that is, you could say, how is this possible if they use the same substrate? Because it's not just the substrate. The substrate may be the same, but and there is, even with the substrate, or differences, for example, how pure it is, or how how it's dissolved and whatnot. But more importantly, each assay also has cofactors. So you think about co-lipase that is usually needed for any lipase activity, pancreatic lipase activity. You have bile acids that are needed to really emulsify the fat, and therefore also help at the interface of the fat, in this case the substrate and the enzyme. And if you don't have those bile acids, that whole interface exchange really changes. Temperature may be important, pH may be important. So there's many other factors that play a role in the ultimate result. So when you try to determine whether an assay specifically measures pancreatic lipase and thus is specific for diagnosing pancreatitis, you actually want to see whether what you're measuring is truly just pancreatic lipase. And the easiest way to do that is to evaluate dogs with pancreatic gastroatrophy. And here I have an example for you where you can see in the top left corner, I have a pancreas from a healthy dog. And you can see the nice glandular structure, great blood supply. And you can just imagine how this pancreas synthesizes and secretes all these enzymes, enzymogens that come from the exogenous pancreas. And then on the contrast here, you have on the bottom right, you have a pancreas from a dog with exogenous pancreas insufficiency, more specifically from a dog with pancreatic gastroatrophy. And you can see that all that's left here is a little bit of connective tissue. Maybe there's a few islets of Langerhans if you look at it histopathologically, but really you can imagine that this pancreas cannot synthesize any more pancreatic enzymes and therefore does not synthesize pancreatic lipase. So now when you go ahead and you actually measure serum lipase activity or pancreatic lipase immunoactivity with an immunologic assay, this is what you'd find. Here you can see 50 dogs where we've done exactly them. These 50 dogs have exogenous pancreatic insufficiency. In fact, they have exogenous pancreatic insufficiency because of pancreatic gastroatrophy. And in the first column here, you can see that this is the pancreatic lipase estimated by the SPEC-CPL assay. And what you can see is that virtually every single dog is below the detection limit of the assay. There's one single dog here that's 50, which still is very, very low. I mean, remember that the detection limit of this assay, 30 micrograms per liter. So this one dog has 50. Upper limit of the reference range is 200. So we're very far away from the upper limit reference range. We're even not in the normal range of most of these dogs. Now, what you can see in the next column over is the same 50 dogs, but now measured with the Sentinel DGGR assay. This is one DGGR assay that's run on a standard chemistry analyzer, and you can see that many of these dogs have completely normal serum lipase activities, suggesting that what you're measuring here, what I'm circling, is not coming from the exogenous pancreas. It's coming from somewhere else. So that may be lipoprotein lipase, maybe hepatic lipase, maybe gastric lipase. And then one over, you have the urolyzer DGGR. And this is also DGGR assay, but this one is an in-house analyzer. This is the only small machine that measures DGGR lipase activity. And what you can see here is, number one, also many of these dogs have completely normal serum lipase activities. But what's more important, when you compare the second column to the third column, what you can see is that the pictures look completely different. They're not just transposed where you would have this image here, maybe a little bit higher or a little bit lower. No, these two images look completely different. And that's a very important point, because it reminds us that just because two assays utilize the same substrate, in this case DGGR, the results may not be the same. They may not be measuring the same lipase in the serum. And therefore, each one of these DGGR lipase activity assays would have to be analyzed separately, would have to be validated separately, would have its own reference interval. And that's really, really important. And that's unfortunately not the case on the marketplace. And in the last column, you have the Fuji DryChem VLIP slide. So this is probably, when you look at all these columns, this has the most dogs where serum lipase activity is smack in the reference range. And so again, this suggests that this assay measures all sorts of different lipases in addition to pancreatic lipase. And so again, when you look at all of these pictures here in this scenario, and remember, these are just some traditional DGGR lipase assay, the Fuji DryChem, and you compare that to an immunologic assay, the only one that measures pancreatic lipase specifically here is, in fact, the SPEC CPL. Of course, you'll see later on that there are, in fact, DGGR lipase assays that also specifically measure pancreatic lipase. Where does the lipase activity come from that we're here measuring here falsely? And we've done some studies that show that, number one, it's extrapancreatic lipases, so hepatic lipase, lipoprotein lipase, for example. It's also an enzyme called PLRP2. This is pancreatic lipase-related protein 2. It is an enzyme that is very closely related to pancreatic lipase, but it's not the same. Also, esterases, proteinases, hemoglobin, all of this could be falsely measuring, be detected by the DGGR assay. And we did one study where we stimulated the release of hepatic and lipoprotein lipase in dogs and cats by giving them some heparin. And what you can see here, this is the data from cats. In blue down there, you can see the line where the SPEC FPL shows you that basically there is absolutely no change when we administer heparin, because of course the SPEC FPL assay measures this immunologically, and therefore there's no change. But you can also see that the DGGR assay, and this is a sentinel DGGR assay, you can see that here there's a blip up. And so basically here, what's falsely detected here is not pancreatic lipase, but it's actually hepatic lipase and lipoprotein lipase. And PLRP2, as I mentioned, is a very interesting molecule because it's very similar to pancreatic lipase, but it's expressed in many other cells in addition to acinar cells. And basically, we showed this here. You can see here in black this time, the SPEC CPL of a serum sample where we measure DGGR lipase. And then in blue, you can see we added on PLRP2, and the DGGR lipase activity actually goes up, dramatically goes up. Now, the question, of course, is this a physiologic amount of PLRP2? And that we can't tell you yet, but it just shows you that when using this specific DGGR lipase assay, which was the sentinel assay, you have a false detection of PLRP2. And here you can see that PLRP2 is expressed in the pancreas of dogs, but it's also expressed in the kidney of dogs. There was one study, the Swiss group around Peter Koch has been propagating DGGR lipase assays for many years, and this was one of their studies. And in their study, this was the Roche assay. They had 142 dogs, and they basically correlated SPEC CPL and DGGR lipase activity. And what they found was that the Cohen's kappa coefficient was 0.7 to 0.79. Now, you know, you can look up in any table about Cohen's coefficient and say, well, is that a good correlation or bad correlation? And we'll tell you it's pretty good correlation. It says that because the Cohen's kappa coefficient was developed to compare and not objective criteria, but subjective criteria. So if you have 5 radiologists looking at the same radiograph, we're going to use Cohen's kappa coefficient to compare how well they agree. And if they agree 0.7 to 0.79, by all means, that's great agreement. You'd look at one slide and show it to 5 clinical pathologists or anatomic pathologists. If they have an agreement of 0.7 to 0.79, that's pretty good. But if you take 2 calcium assays and you compare how much calcium is in a sample, and you get an agreement of 0.7 to 0.79, you would say those 2 assays do not measure the same thing. They're not interchangeable. And just like that, the SPECS-EPL and this Roche DGGR lipase assay do not measure the same thing. And I showed you what they potentially can measure. And there was another study done at the University of Illinois. This used a different DGGR assay. And in this study, they had 30 dogs that had clinical signs suggestive of pancreatitis, but only 15 ended up having pancreatitis and 15 did not. And here they compared a 1-2 DIG assay to their DGGR assay at the time. And you can see that the sensitivity increased dramatically from 60 to 93%. But at the same time, their specificity dropped from 73% to 53%. And so basically, now you can see, how am I going to compare those two? Well, you compare them by calculating diagnostic accuracy, and you do that by multiplying sensitivity and specificity. And for the 1-2 DIG assay, that's 60% times 73% is about 42%. And for the DGGR assay, 93% and 93% times 53%, about 46%. So you have an accuracy of 42% compared to 46%. So in this study, the DGGR assay that they used was no better than the 1-2 DIG assay that they used in this study. And there was a feline study from, again, the Koch group, which also showed a Cohen's kappa coefficient of 0.7. So once again, great agreement if you look at Cohen's kappa coefficient, but not such great agreement if you really look at how 2 assays that supposedly measure the same thing agree with each other. And for those of you who are still critical and think, well, how, why would this be a problem? Just think of a study that was recently done in cats where they looked at the Cohen's kappa coefficient of alkaline phosphatase activity and total T4 concentration for the diagnosis of hyperthyroidism. And guess what? The Cohen's kappa coefficient was 0.7, meaning, if you would be happy to forego measuring total T4 concentration forever and only measures alkaline phosphatase activity for the diagnosis of pancreatitis, then, the SPECS-FPL and the DGGR lipase assay that was used in this study, which was the Roche DGGR lipase assay, then that would be acceptable. But clearly you wouldn't agree with me on that. Clearly you would say, no, I do need my total T4 concentration for diagnosing hyperthyroidism in cats. And so therefore, it would make absolutely no sense to measure alkaline phosphatase activity instead. What about the new Catalyst Pancreatic Lipase assay? It is an in-house assay for the Catalyst analyzer. And it's, in fact, the first DGGR lipase assay that is on a dry chemistry analyzer. Now, this may not mean a whole lot, but I'll tell you a little bit more of a history, which is that Fuji had tried to get DGGR on a dry chemistry slide for many, many years. And finally, about 15 years ago, they published a paper where the Fuji scientists said, this is simply impossible. You cannot put DGGR on a dry chemistry slide because it's not stable. It falls apart. And now, IDEXX has managed to put it on a dry chemistry slide, and that is proprietary technology. So I can't tell you how they did it. I have some inkling because, basically the instability is due to the pH at which the assay is being run. So I assume that they basically changed the pH during the assay procedure, which is, of course, technologically possible, but not an easy thing to do. It is also the first DGGR-based lipase assay that appears to be specific for the measurement of pancreatic lipase, again, through proprietary technology. And remember, I told you that before, that basically dogs with pancreatic vascular atrophy are the dogs where we evaluate this in, and I'll show you this in a second. Now, the internal analytical validation has been completed of this assay. The external validation is currently underway, and it provides a numerical result that has been aligned with the spec CPL and spec FPL. What does that mean? If you get a spec CPL of 600 micrograms per liter, you would also get a value of 600 units per liter on the Catalyst PL. So it's interchangeable, which makes it ideal when you want to use it for monitoring, where you actually have a laboratory value of the spec CPL, or the other way around, you have a value in-house because a patient came in an emergency, and now you want to check that down the line for monitoring treatment or outcome. It is really ideal for patients with acute clinical signs that require immediate and accurate results. And so more data clearly is underway, the external analytical validation data. Hopefully I could share that in maybe another couple of months. This is what I promised you is the data that shows that in fact this assay is specific for the measuring pancreatic lipase. You can see in the center graph here, you can see measurement of spec CPL in dogs that have pancreatic acinar atrophy. And you can see that virtually all dogs are below the working range of the assay. There's 5 samples that have a value that is above 30, above the working range. But even those few dogs, those 5 dogs, are only barely above that. On the right-hand side, you can see the same dogs being measured with a 1,2 diglyceride assay. And now 15 of the samples are above the lower 25% of the working range. And so you can see a significant number here is actually what I would call completely normal, suggesting that what's being measured here is not pancreatic lipase. But here on the very left-hand side, you see the Catalyst PL. And here, only 3 samples are below 30 units per liter. So even better slightly than the spec CPL, or in other words, really the same. It is as good as the spec at CPL of being limiting to only measure pancreatic lipase. Also, here is the correlation between the spec assays and the Catalyst PL slide. And what you can see is the correlation is 0.94 for dogs, 0.96 for cats. Again, remember what I told you before. If you had 2 calcium assays, you would want them to agree somewhere in the higher 90% range with each other. And that's exactly what the new Catalyst PL assay achieves. And another thing here is this is a slide that shows you what we call binning, meaning does it change whether you use the spec CPL or whether you use the Catalyst PL? And you can see that while there are some animals that are sort of, where there's a slight disagreement. So in the first line, for example, here's the Catalyst PL is less than 200, and most of the dogs that are less than 200 are also less than 200 micrograms per liter, but 6.2% are in the questionable range, so in the bin right next to it. But a complete disagreement, meaning a Catalyst PL that is less than 200, but a spec CPL that's above 400, 0%. And so you can see that these disagreements are 0% for both the cat and for the dog. And so that is very good agreement, not only mathematically when I tell you what the R value is, but also clinically when we look at the bins. And that's really, really important for diagnostic accuracy. So in summary, and I'm very cautiously saying here, only few assays are currently available that are truly specific for measuring pancreatic lipase and thus pancreatitis. Now, a few means really at the moment, it's the Catalyst PL assay. I have to say a few because there may be other assays in the world that I'm not aware of, but every other DGGR-based assay that I'm aware of is not specific for the measurement of pancreatic lipase. And so depending on what substrate is being used, again, many assays on the marketplace do not use even DGGR, and many assays have never been validated analytically. We don't know whether they work in dogs and cats. We know they work in, some of them work in humans or mice or pigs, but dogs and cats are not mice and pigs or humans. And so they would need to be validated. And even the Koch group in Switzerland has never validated these assays for dogs and cats, has never evaluated patients with pancreatic acinar atrophy. And so we have absolutely no idea how much specific these assays are for the measurement of pancreatic lipase. Again, going back to immunoassays, these use an antibody to specifically recognize a moiety on the pancreatic lipase molecule. And so different lipases would require a different antibody. And so if you use an antibody directed against pancreatic lipase, it will specifically measure pancreatic lipase and thus be specific for pancreatitis. Currently worldwide, there's 5 assay platforms available. We're going to briefly talk about 4 of them. The first one is the SPEC-CPL and SPEC-FPL by IDEXX. The next one is the CPLI and FPLI by Laboclin in Germany. And by the way, the CPLI and FPLI, that's actually the name of the parameter. So, in the US, we say we measure CPLI, canine pancreatic lipase immunoactivity, as measured by SPEC-CPL, or the FPLI by SPEC-FPL. Laboclin has gone ahead and named their assay that way. You also see it's not registered, of course, because you can't register that. And then the SNAP CPL, SNAP FPL, also again by IDEXX, the VETSCAN CPL by Zoetis, and the VCheck CPL. There's also an FPL by Bionode in Korea. And again, this is data from the SPEC-CPL assay, and you can see that, as I already shown you, dogs with EPI, pancreatic atrophy, exocrine pancreatic insufficiency, have dramatically decreased CPLI or SPEC-CPL values. And the SPEC-CPL test by IDEXX and the SPEC-FPL have been fully analytically validated by IDEXX, and many assays or many studies are available that evaluate this test for the diagnosis of pancreatitis. And in fact, this is the largest study that was ever done in dogs. It was done by the group around David Tweed, actually many years ago now, almost 20 years ago. And what they showed was that the specificity was 78% and the sensitivity of 93%. That's a little bit of a lower specificity than other papers. Other papers have shown specificities in the mid 90% range. The sensitivity is a little bit higher than others have reported, which is often in the middle 80s. But nonetheless, this is highly sensitive and highly specific for the diagnosis of pancreatitis in dogs. This is the study by Foreman in cats, and you can see here that they had many different groups of cats, healthy cats, cats that definitely did not have pancreatitis DNP, and cats that definitely had pancreatitis DP. And you can see that the cats that definitely don't have pancreatitis, virtually all of them are within the reference range. One is slightly above it, but in all reality, that is highly specific. And on the other side, you have 9 cats that had pancreatitis. You can see that 7 of them have quite high FPLI or SPEC-FPL numbers. So again, highly sensitive, highly specific. The SNAP test has been shown, both the SNAP FPL and SNAP CPL have been shown to correlate very well with the SPEC-CPL and the SPEC-FPL test. And a normal result pretty much rules out pancreatitis. Abnormal result suggests pancreatitis, and then it has to be confirmed by actually measuring SPEC-CPL/SPEC-FPL. For the SNAP test, we don't want to spend too much time on it, but I believe that there's a human factor. You have to read it, and so sometimes that's leads to some either the person holds it upside down or has some misconception. And so I would always show these, unless you use a SNAP reader, which of course it would be fantastic. I would always show this to the second investigator. And we didn't really used to know a lot about lateral flow devices. These are lateral flow devices, but now after COVID-19, everybody is familiar with these. What's a little bit different about these SNAP devices is that COVID test, for example, any color development. So the device on the left would be just as positive as the device on the right. But in this case, this is not the case in the SNAP devices for the dog and for the cat for pancreatitis. We compare the patient dot, and that is the dot basically on the right-hand side here, with the control spot, which is here. And then on the device on the left, that spot is lighter than the control spot. So this is a normal device, versus on the right-hand side, the patient spot is darker than the control spot. So this would be an abnormal device. Again, that is different from, for example, a COVID-19 test where any color development would in fact be problematic. And why do we need to send it in if it's an abnormal SNAP test? Well, that is because when you have a SPEC test, it either can be normal in the dog, less than 200 micrograms per liter. It can be suggestive of pancreatitis when it's above 400 micrograms per liter, but it could also be in the questionable or gray range when it's between 200 and 400 micrograms per liter. And of course, the SNAP device is either normal or it's abnormal, negative or positive, or normal and abnormal. And you can see that, of course, we have to decide where the gray range falls in. And basically, when the assay was designed, the positive both encompass the gray as well as the pancreatitis range, and therefore we need to send it in to actually get a true value. The VET scan, we don't want to talk about it too long. It had never previously been validated in the peer-reviewed literature. So we went ahead and did a validation study, and we showed poor linearity, which of course is especially important because the assay only has a maximum detectable value of 600 to 700 micrograms per liter. And so that's really not very high. Shows poor precision with an intra-assay variability of 25.1%. and poor reproducibility with an inter-assay variability of 31.8%. And just as a reference point, if you buy an assay from Siemens or Roche or whatever, they really don't find inter and intra-assay variabilities that are much higher than 10% acceptable. And so both of these numbers would be unacceptable. I mean, you'd say, what does this practically mean for me? It means that if you measure the same result over and over, you will get different results. And I'll just show you one example here. Or two examples. This is a SPEC CPL test that's 179 micrograms per liter. And you can see that in this scenario, there is absolutely no problem with this. While it's not plus minus 60 for one of these detectors, for one of these measurements, it certainly is close enough, and they're all 4 in reference intervals, so that would not be a problem. But this one here is 351 microgram per liter. And the first thing is that you notice that none of the 4 analyzers reads a value that's plus minus 60 or plus minus 50 to the measured value. But you also realize that this result from the SPEC CPL is in a questionable range, but close to the range of diagnosing pancreatitis. So if you'd get that back, you'd say, boy, I'm really worried about this pancreas and I need to recheck this in a week, or if it's an acute setting, maybe in 24 hours. Whereas the first detector, the first VET scan reads 460, and of course that is in the pancreatitis bin, so that would be fine. But the other 3 also, it's completely normal. And of course, in a practice setting, you wouldn't measure the analyte 4 times. You would measure a sample once, and then you would basically utilize that for the diagnosis. And so under field conditions, it doesn't perform like it's indicated by the manufacturer, and precision and reproducibly are unacceptably low at this point. Now, there could be some updates. I'm not aware that that has changed dramatically the performance of the assay, but certainly that is possible. Now, the VCheck CPL by Bionode, we can't really talk about it. I've done some studies on it. There have been some updates on the assay. There have been some paper from Sweden on this, but again, I'm not supposed to talk about this. Pancreatic cytology and biopsy, just very quickly. This is a picture that I gotten from a colleague in Germany. I really love this picture. I keep showing it because it shows you on the bottom right-hand side, there are some acinar cells, and they basically tell you that you're in the pancreas and not in some other organ, abdominal cavity. But also you see all these neutrophils, and you see the mast cells up here. And so you have pancreas, you have neutrophils, you have mast cells, you have pancreatitis. And so in essence, this cytology is very good at confirming pancreatitis, if you can do that. And so the specificity is extremely high, but the sensitivity is not very good because, again, remember that the pancreas is this longitudinal organ. And so you'd have to stick it many, many times. And even then you may miss the nidus of inflammation. And so again, it's good to confirm pancreatitis. It's not so good to rule out pancreatitis. But the other problem is that, many people are still worried about finally aspirating the pancreas. we shouldn't really worry about it too much. It's been multiple studies have shown that it's completely safe, has been shown to be safe in humans, but still people are worried about this. And pathology is kind of the same way. It's great to confirm it, but it's not so good to rule it out. And the problem is that, of course, that's much more invasive. And so most patients, that's not in their best interest to get a biopsy of the pancreas. So in conclusion, number one, pancreatitis is best diagnosed by an integration of the clinical findings, imaging results, and measurement of pancreatic lipase in serum. Number two, the success of pancreatic ultrasound is dependent on disease severity, operator experience, and the level of suspicion. Number three, there is no substrate that is inherently specific for the measurement of pancreatic lipase. Number four is that many lipase activity and lipase immunoactivity assays, you've seen that it's not just lipase activity assays, fail basic validation criteria, either have never been validated or fail the validation criteria. And the Catalyst Pancreatic Lipase test has been designed to be specific for the measurement of pancreatic lipase. SPEC CPL, SPEC FPL tests, Catalyst Pancreatic Lipase, and SNP CPL, SNP FPL are currently the most sensitive and specific diagnostic tests that are available for the diagnosis of pancreatitis in both dogs and cats. With that, thank you very much for your attention. I'd be more than happy to try to answer some questions. Thank you.
Thank you so much, Dr. Steiner. What a fabulous presentation. Let's transition to Q&A.
Thank you.
Okay, great. We have some comments coming in just thanking you for the great information today. Here's a question for you. Can you tell us about any recommendations you have for monitoring dogs and or cats with acute pancreatitis?
Yeah, I think, that actually is a great question. And I think that's changing slightly. In the past, people just looked at clinical signs. And the truth was that all we had was symptomatic and supportive care. And so basically you just looked at the patient, looked for complications on a daily basis. I have actually monitored patients for many years now with the SPEC CPL, SPEC FPL, because I have it in-house very easy. So I do it every 2 days. And I think now that we have a medication available that basically specifically treats pancreatitis, now it's actually more important even to monitor these patients. And so I think, every couple of days is probably a good idea to see where is that lipase going. And I should say that, there's some people in Japan have used C-reactive protein for monitoring rather than SPEC CPL, SPEC FPL pancreatic lipase. And in Japan, that has panned out supposedly. We have done studies here that have looked at this and compared cytokines, have compared C-reactive protein, and have compared measurement of pancreatic lipase. And the only one that reliably followed clinical development was actually the measuring of pancreatic lipase. So I don't use C-reactive protein. I don't find it useful in my hands. Again, there's still some data coming out of Japan where they find that useful. That may have something to do with the severity they start out with. So if you start at you only look at extremely severe patients, then that may be a different story. But for the patients, when we look at all the patients together, the measurement of pancreatic lipase certainly is far better.
Okay, great. We've got a few more. I think we have time here. As a follow-up, what about recommendations for monitoring with for chronic as opposed to acute pancreatitis?
Yeah, so with chronic pancreatitis, it sort of changes over time. Initially when you change things. So initially, we look for risk factors. We adjust the diet. We may need to additional medications for hypertriglyceridemia, for example. We may need to change a medication because the dog's on a medication that's suspected of being of causing pancreatitis. Whenever we change something, we want to measure it again 2 weeks later. And so that's initially. But then, of course, especially in cats, you will get to a point where there's no change anymore. You've measured it, 3 times every 2 weeks, and you've changed things, and it's still the same SPEC FPL. Measuring pancreatic lipase then every 2 weeks from then on is of no help anymore. So you want to measure it while the disease is dynamic. And then when the disease is more stable, and in dogs, we hope to get it stable within the reference range. And in cats, very often that's not the case. We're going to be stuck with a cat that has a mild elevation of pancreatic lipase long term. Then we're just going to decrease the frequency of how often we're going to do that.
Wonderful. Thanks for taking us through the distinctions there. So we have time for one more question. How does the blood sample affect results? You know, for if there's hemolysis, not fasted, etc.
Yeah. So you know, that again is different for every assay, and we've evaluated different activity assays. We've evaluated different immunoassays. For immunoassays, there's absolutely no impact, and that is because you think about it. You know, you measure the color measurement, the color change after the sample is long gone. You know, you let the sample incubate, but then you wash the plate. So there is no color interference anymore. For the lipase activity assays, that's different for every assay. For the Catalyst, there seems to be no interference, but for others, there is clear-cut interference. Like, for example, the VLIP assay, we know that hemolysis will decrease lipase activity by up to 50% when it's severe. So we're talking quite severe changes with some assays, not with others. But again, that needs to be shown for every assay. And so the papers that are presented, that's why I made this point, it's really important to analytically validate each assay specifically for dogs and cats, because each assay, a human is not a dog, is not a cat. And so it needs to be validated in order to show that these interfering substances have no interference.
Great. That seems like a perfect spot to wrap things up for Q&A today. Thank you again so much, Dr. Steiner and Dr. Schooley, for kicking things off earlier. We apologize if we didn't get to everyone's questions. So thank you both so much.